Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. In this episode, an update on RX Kids, a program in Flint, Michigan that prescribes cash to expecting and new mothers. Dr. Mona Hanna, a pediatrician and the Associate Dean for Public Health at Michigan State University College of Human Medicine, and Dr. Miriam Laker, Director of Research for GiveDirectly, tell me about the launch of the program and what they've seen happen in its first year, and why cash support may be one of the most important health interventions with global evidence of its success. Just a note that this podcast episode was recorded in late October, and given the outcome of the presidential election, it's now a more important bipartisan conversation than ever. Let's listen. Dr. Mona Hanna and Dr. Miriam Laker, thank you so much for joining us. Today, we're actually going to start talking with you, Mona, because you've been on the podcast before. We did an episode about this program, RX Kids, when it was first launching, and we're back to talk about some updates. But first of all, can you help our listeners remind them what RX Kids is and what this program does?
Absolutely. It is great to be back on the podcast. Thank you for having us back on. So RX Kids is super exciting. I think it's the most exciting thing happening in public health right now. And we call RX Kids a prescription for health, hope, and opportunity. RX Kids is the nation's first citywide, universal, and unconditional maternal and infant cash prescription program. So what that means is everybody in Flint, Michigan, every pregnant person receives unconditional cash during mid-pregnancy. And every baby gets unconditional cash for that first year of life. So RX Kids launched in Flint, Michigan in January of 2024. And it's only spreading.
And how much cash are we talking about?
So every mom gets a one-time lump sum amount of $1,500 after 20 weeks of pregnancy. And then once the baby's born, it's $6,000 for the first year of life, distributed as $500 a month for the first 12 months. So in total, it's $7,500. And since RX Kids launched in January, we have prescribed over $4 million in cash to over 1,000 mamas. And when you kind of look at the numbers, that reaches almost 100% of the newborns that have been born in Flint.
And just to clarify, this is just cash. They can spend it on whatever they want, whatever they need, right?
Yeah. So, it turns out that the perinatal period, so this period right before childbirth and extending to the first year of life, is actually when families are the poorest. So if you look at the entire life course, families are poorest right around this window of childbirth. And kind of as a pediatrician, as a public health person, we also know that this is a window that is so critical for neurodevelopment. Like what happens in this window really shapes your entire life course. So to be able to kind of prevent the pathogen of poverty, that toxicity that happens because of deprivation, these cash prescriptions are unconditional. Folks don't have to do certain things. They don't have to go through lots of hoops or, do lots of different requirements to get this cash. And this is really kind of based on that global evidence and also the domestic evidence. When we expanded the child tax credit, those were unconditional cash allowances that went to the, millions and millions of families. And families, when they have cash, they spend it on what their kids need. And that's also kind of built on lots of evidence.
So the program's been effective for a little while now. You've given away millions of dollars. And what have you learned so far about how this is working?
Yeah, that's an amazing question. And I'm an academic and Miriam's an academic, and we have a big research team, and we're looking at lots of different things at the individual level via surveys. But because this is a population intervention, we're also leaning on big administrative data because we've achieved that full saturation. So we're leaning on like Medicaid claims data and birth certificate data and child welfare data. So there is a lot of research. But before I get into the outcomes, I also want to share, and I know Miriam will talk about this, that we actually don't need more research. The work of child allowances, of child cash transfers, although it sounds like novel and new and exciting, and we're the first place to do this at a city level, it's really built on decades, if not a century, of global evidence. So yes, we're working on outcomes, we're sharing outcomes, but my colleague actually calls this the evidence-based policy of evidence-based policies. Like, if we did no research, that would also be okay, because there are mountains and mountains of research. But let me tell you what we've learned. So what we have learned is that it's pretty awesome. Like, it's gone seamlessly because of our amazing cash administrator, GiveDirectly. Families are getting these dollars quickly, and by and large, they're spending it on, number one, baby supplies, because babies are expensive and they need stuff. So by and large, these dollars are going for cribs and car seats and diapers and wipes and baby clothes. But then folks we're learning, spending this money on food, transportation, rent, utilities. And those are the things that people by and large spend cash transfers on, based on, once again, global and domestic evidence. We also did a research earlier this summer. So we surveyed babies that were born, the RX Kids babies born this year. We also surveyed babies born outside of Flint, and we surveyed parents who had a baby last year. So we had 3 different control populations. And what we learned was that our RX Kids families in Flint, and just by context, Flint is the poorest city in Michigan, and actually Flint has the highest child poverty rate in the nation. So Flint is a very, very poor city, which is one of the reasons that we launched the program in Flint. And what we're finding from our survey, using kind of difference kind of methodology, is that our families in Flint have less hardship. So they are able to pay their rent on time. They have less back-owed rent. We've had no evictions in our families this year among our low-income families, which is amazing. They have more food satisfaction. They have less diaper hardship. So we're absolutely making a dent on our prime kind of outcome, which is family financial security. But we're also finding that our families feel better. So our moms have less depression, so less postpartum depression. They have less anxiety. They rank their mental health higher. These are some of my favorite findings. We see improved maternal well-being. Our moms feel more loved, more respected, more valued, more empowered. And this has been a really important part of our program. Yes, we're trying to eliminate poverty for babies, and we're trying to improve health equity, but we're also trying to share a different message. We're trying to change that narrative, and we're trying to really convey that this is how we're supposed to care for each other as a society. This is how we're supposed to reimagine that social contract and really be like other peer nations where these kinds of things are automatically done, especially for our youngest children.
The timing of all of this feels significant. First of all, it's been 10 years since Flint was in the headlines for a very different story, and it's an election year, and the idea of cash support is on people's minds. So tell us about the confluence of those things.
Yeah, ever since kind of the uncovering of the Flint water crisis, our work in this community has been about really kind of working hand in hand with our community partners on the recovery, but really sharing a different story of Flint so that folks don't think of Flint as a city that poisoned its children, but really come away with what have we been able to do next. And that is definitely the narrative that we are trying to convey, is here comes this vision, this idea from a place that literally failed to protect children and is redefining how we should be caring for children. And that has really been so much of what has driven our work in this city, is doing awesome things for Flint kids, but really sharing those best practices with communities all over the place. And the timing is beautiful with the presidential election. And that's really kind of what's captivated this work and really has garnered interest in many other states. The design of RX Kids is laser focused on moms and babies. It's time limited. It's actually really low cost compared to other programs out there. It is built on the heels of the incredible success of the expanded child tax credit, which was not renewed. So it was purposeful in our design to kind of keep the work of child cash transfers in the public imagination imagination so that we can continue to inform state and national policy. So we are kind of really excited to be able to share RX Kids in a very kind of bipartisan way. We also have a Republican senator in Northern Michigan who just wrote an opinion piece about why he, as a pro-life Christian Republican, also supports RX Kids. Everybody should love babies. Everybody should want healthy people, just like everybody should want clean water and clean air. As a pediatrician, my constituency is children. And it's wonderful to see something that has been really kind of picked up by so many different kind of perspectives as something that we should do for more kids everywhere.
So I want to zoom out a little bit here. And Miriam, you're joining us from Uganda, but you are the director of research for GiveDirectly, which is the program that administers this RX Kids program. Can you tell us a little bit about GiveDirectly and their relationship to RX Kids?
Happily. So thanks for having me on here, Lindsay. Just excited to share the platform with Dr. Mona as well. So like she said, GiveDirectly is the administrator for the RX Kids project, and we're excited about being able to partner in this. But just zooming out a little bit more. So GiveDirectly is actually an international organization. We've been doing this kind of work for about a decade right now. So it's an international organization that helps donors to directly get cash to people living in extreme poverty all over the world. Right now, we are working in 12 countries and we address people living in extreme poverty. Our cash transfers, just like for the Flint, the RX Kids, is unconditional cash. Every household is given unconditional cash. And the background to this is that we believe that people in poverty know what is best for them. And if you let people make their own decisions, then you're able to address many issues at the same time. And so GiveDirectly initially started off in Africa, in Kenya in particular, increased to run in more countries in Africa. But then in 2020, during the pandemic, we opened our US office, and that is when we started doing work in the US, working with people living in extreme poverty. So actually, RX Kids is just one of the projects that we have running in the US.
Putting money in the hands of people who need it, what kinds of things do they spend it on? How does this money go to help them?
So the most interesting thing is that this answer is one of those generic answers. It's almost a copy and paste, because wherever we have worked in the world, people are people. The needs are the same. They're going to use their money for the same thing. And since we are focusing on children, I'll start with the child perspective. One of the things that most people use their cash transfers on is food. And families move from having to decide when they're going to eat, who is going to eat, to telling us that they're able to feed their children 2 to 3 meals a day and diversify the meal. So they're getting away from just feeding their children on corn to feeding them on carbohydrates and protein. So that is one thing. People are sending their children to school. A lot of children stay home, not because parents don't want them to go to school, but because they cannot afford to send them to school. So children are able to go to school. A very interesting finding that just came out very recently from one of our works that are being evaluated in Kenya, found that actually there was a significant reduction in infant and child mortality, which is exciting to make public, but we sort of know that this is going to happen. Because if you think about the public health system, so my background is in tropical medicine and international health, and one of the things that is like top of the goal is reducing infant and child mortality and maternal mortality. Policies are out there, health facilities are improved, and the question keeps being, why are we not seeing a reduction as fast as it should happen? But once you put cash in the hands of people, suddenly there's more uptake of immunization. Suddenly mothers are having babies in hospital, and therefore the mothers are surviving, the babies are surviving. Suddenly mothers are getting the right food for their children. No one is teaching them how to do this because they know how. So this study saw a reduction in infant mortality of almost 50%. And this is with no one telling the mothers what to do. And so that's some of the amazing things that Cash does. But in addition to that, because our normal programming is giving a large lump sum. So instead of small cash transfers, we give households up to $1,000. And in Africa, that is a lot of money. So what we've seen is that a lot of families first meet their immediate needs, their basic needs, and then they have enough left over to invest in some kind of wealth generating project. Usually it's a business, and that way they are assured of some kind of sustained income for their families beyond the duration of the project.
I'm struck by the naming of both of these groups. GiveDirectly is a very specific name, and it's exactly what you do. I'm also struck by the fact that it's called RX Kids, the program in Flint. Can you tell us money as a prescription, cash as a prescription? What does that mean? And I'll start with Miriam.
Perfect. So like I said, my background is in medicine. And one of the things that I noticed in the work that I was doing, because I worked with people living in extreme poverty for a long time, was that even when you prescribed medication, sometimes the medicine wasn't there. I remember when antiretroviral therapy was new, some of the drugs needed people to take the drugs with food. And people said, I don't have food, so I cannot take the drugs. And so with RX Kids, you're actually prescribing money, and people are therefore able to meet whatever needs that money should be able to meet for them. It might be food, it might be more time with their children. We usually take that for granted. Sometimes RCT or research from cash transfers come out, and the report is that mothers are working less, and people go up in arms. They're like, you're making people lazy. And yet when you go deeper, you find people are just spending more time with their children. So you prescribe money for them so they're able to spend more time with their children. They're able to, like in this study that was done in Kenya, they found that mothers towards the end of their pregnancy were able to take time off work and just to rest at home. And for the first 3 months after the babies were born, they were able to stay home with their children. So in a sense, money in this case is actually treatment that people need, and it's able to address so many things at the same time. And that's why I love the name RX Kids.
You've touched on something here, and I want to go to you, Mona, maybe for a final thought. The idea of giving no strings attached cash to people is, as you said, evidence-based. We've seen it work all over the world. Is there still stigma that you're having to push through to get full buy-in in something like this?
We've had surprisingly very little pushback for our program, and we've had a lot of excitement from even more conservative communities. And I think it's for several reasons. One is it's really time limited. It's for moms and babies. And, it's just this, once again, this porous time in the life course, this tremendous time of neurodevelopment. Your brain doubles in size in that first year of life, and it ends at 12 months. So I think that's kind of made it more palatable. And it's also it's launching in the US in this bizarre kind of post-Dobbs era where there's been kind of bipartisan interest in things that are pro-family and pro-child. So that's also kind of given us, I think, less pushback. The third reason, which touches on your previous question, is that we're really framing it in the health context. It is called RX Kids on purpose, to really reiterate that poverty is a health crisis. It is the leading social determinant of health. I, as a practicing pediatrician to this day, for decades longed for the ability to prescribe away poverty. Being a pediatrician in the poorest city, the highest child poverty in the nation, like when I am holding a little baby in my arms, a newborn, and that newborn is staring at me, and I know what it means to grow up in that newborn's zip code, and I know that what the consequences of being born into and growing up in deprivation are, it has been maddening. It has felt like my hands have been tied, and I have wanted to go into my doctor's bag and prescribe away poverty. And this does that. This finally enables healthcare providers, doctors, to do what we have wanted to do for a long time, then that is to prescribe money as medicine to address kind of this root cause issue of so many ailments that we are unable to treat.
Well, congratulations to both of you for the success of this program and for being such eloquent and passionate advocates for evidence-based solutions like these. Thank you so much for coming on Public Health on Call.
Thank you, Lindsay.
Thank you, Lindsay.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.